Yes, sir.
Okay, thank you. Just give me a go ahead once it becomes live.
I think, I think it's live now.
Okay, great. So welcome everyone for the cardio colloquium. With this, I'd like to invite our esteemed faculty. So we have Professor Sandeep Mishra. So sir definitely doesn't need any introduction. Sir is a director of the Institute of Cardiac Sciences, NIMS Hospital, Jaipur. He's also the Vice Chancellor and President of NIMS, University, Rajasthan. He's the ex-professor of cardiology at AIMS, New Delhi. So we welcome you here today to moderate the session. We
Thank
also
you.
have Dr. Piyush Jain. Sir is the Director of Non-Invasive Cardiology at Fortis Escorts, New Delhi. We have Dr. Narendra Chauhan as well, Senior Director, Interventional Cardiology and Structural Health Disease, Medanta Heart Institute, Medanta, the Medicity, Gurgaon. Welcome, sir. And we also have very senior Dr. Vidyut Jain, is a senior cardiologist from Choitram Hospital and Care CHL Hospital at Indore. We welcome you all here today. So, cardio colloquium, today we are going to discuss RAS blockers in acute MI from SAVE to Paradise MI. Do we have a verdict? Over to you, Dr. Mishra.
Good evening, everybody. Thank you, Dr. Ronak, for having me here. And I think we are going to discuss something which is very burning in the minds of general physician, at least, because cardiologists, of course, have a lot of more information. But for general physicians and for those who are not exactly updated as what is happening, I think this is a very important topic, which is renal angiotensin system blockers in acute MI from SAVE to Paradise MI. So can I have the next slide, please? So as you can see, various things have been tried. We know about ACE inhibitors, we know about ARBs, and the special context that we are talking of is post-MI patients. And we have something new that has also come up, like ARNI, not very new to the field of heart failure, but in the field of STEMI, it is somewhat newer entrant. And so we would like to know where all these three drugs, that group of drugs that we are talking of, stand at the moment. So that is our whole endeavor. So the first one that we will discuss is, of course, AC inhibitors. And if you notice, there are two categories of trials. One is high risk patients, higher risk patients, where this has been given for long term basis. Particularly, you have lower ejection fraction less than 40%, SAVE trial, those with clinical heart failure, AIRI trial, and those with wall motion score and EF less than 35%, the TRACE trial. But at the same time, we have also some evidence of ACE inhibitor, albeit short term, in patients who are not at high risk, but who are post MI. And we have consensus 2 trial, GC3, and ISIS 4 trial. So these are 3 trials in those non high risk groups as well. Coming to the high risk patients, we have this SAVE trial, which was published in 1992, involving more than 2,000 patients. Captopril started after 3 days, or at least after 2 days, between 3 to 16 days, and they looked at mortality and morbidity reduction. Then AIRI trial, which was published in 1993, with a population of more than 2,000. Here, ramipril was used again, starting 3 days to 9 days. So notice it is not the first day, but the drugs have been started between 3 days to 9 days after MI, and it also showed significant mortality reduction. The third one that we will briefly touch upon is the TRACE trial with carendopril, again started between after day 3 or at day or after day 3 to day 7. And again, with higher risk coming in terms of reduced left ventricular ejection fraction. And again, looking at mortality, mortality from cardiovascular causes, sudden cardiac death, and development of severe heart failure. So these are the 3 trials that we will touch upon to get a sample of what ACE inhibitors are doing in post-MI patients. Next, please. So if you look briefly, The target dose in the SAVE trial was 50 milligram TID. The ARI total dose of 10 milligram given 5 milligram BD, and in TRACE dose of 4 mg OD of Terendopil. And again, as I said, ejection fraction less than 40% for SAVE as judged by MUGA evaluation, and heart failure for ARI patients, clinical evidence or radiographic evidence. And for the Terendopil, the echo left ventricular ejection fraction less than 35%, equal to or less than 35%. The age groups are broad adult age groups, and the follow-up, as you can see, about more than 3 years for SAVE, about 1.5 years for ARI, and more than 2 years for TRACE trial. Next, please. So coming to the SAVE trial, survival and left ventricular enlargement study, published 1992 in NEJM, a randomized double-blind placebo-controlled trial, again with ejection fraction less than 40%, and randomized between 3 to 16 days. The evaluation of ejection fraction done by MUGA. So captopril started 50 milligram TID, and then the mean follow-up was about 3 years. And what it did show was that captopril group showed a significant reduction in mortality by 19% and 25% reduction in recurrent MI. The cavity dilatation was also reduced, and the benefits occurred in patients irrespective of whether they were on beta blockers or not, whether they were lysed or not. So in all group of patients with this reduced ejection fraction less than 40%. So that is the key, and started from the day 3 onwards. Next, please. The second trial that I will touch upon is the ARI trial, which is acute infarction ramipril efficacy. Again, a randomized double-blind placebo-controlled multi-center trial enrolling nearly 2,000 patients. Here, the higher risk being connoted by persistent or transient heart failure. Again, randomized after 3 days or at 3 days to 10 days. Oral ramipril dose total achieved 10 milligram given as 5 milligram BD. And follow-up was more than 1 year, 15 months. Here, ramipril show a very significant reduction in mortality by 27%, 19% reduction in rate of MI and stroke. The benefit being seen at 6 months. Next, please. As you could notice that it was a shorter duration study, only 15 months. So they planned a ARI extension study also with these same patients, enrolling now about 600, more than 600 patients, and following up for nearly 5 years. So 59 months, up to 59 months, up nearly 5 years. Again, what we see is that the benefits of ramipril persisted over a sustained period of even this 4-year period, with a significant relative reduction in mortality of 36% and absolute risk reduction of 11%. Interestingly, the ramipril was discontinued after 1 year, but the benefits seem to persist even later on. So this was the interesting finding of ARI extension study. Next, please. Coming to the TRACE study with Terendopil. Again, same randomized double-blind placebo-controlled multi-center trial with wall motion index of less than equal to 1.2, and then another 2,000 patients. Same time at 3 days of MI, the randomization started, and Terendopil 1 milligram per day was given, maximum up to 4 milligram, and again followed up for more than 4 years. This again showed a significant reduction in mortality, 25%, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. So as you can see, the consistent across the board reduction in mortality and even morbidity in terms of recurrent MI, sudden cardiac death, and other parameters. Next, please. Now coming to other trials which were not so high risk, but again post-MI, here the drug was started generally within first day itself, but persisted treatment for more than 1 month. So here, huge number of patients, ICS-4, nearly 60,000 patients, and it did show survival advantage with this drug. Captopril, DC-3 in 1994, another nearly 20,000 patients with lisinopril, And it did show some reduction in mortality and also left ventricular dysfunction. And then CCS1, about 15,000 patients, again, a reduction in mortality shown with the drug captopril. Next, please. So coming to GC3, as I said, about 20,000 patients. Lisinopril was the drug that was used. More than 1 month period it was used. It started within 24 hours of the symptom onset, and it did show about 12% reduction in mortality, and also better left improvement in severe left ventricular dysfunction. Overall mortality reduction was up to tune of 17% when it was combined with glyceryl trinitroglycerin. Next, please. ISIS-4, a huge trial, 60,000 patients. Again, within 1 day of onset of symptom. As I said, not very high risk. And captopril did show some reduction, although it was small, only 7% odds ratio reduction, with about 5 less deaths per 1,000 patients treated for 1 month. So here you will notice starting early within 1 day and basically completing around 1 month of therapy, but still you could see some mortality reduction and about 5 fewer deaths per 1,000 patients. Next, please. Same story practically with CCS1 also, again with captopril, again 15,000 patients, no high risk features. Again, lower mortality was found in anterior wall infarction of when given captopril, and here 6 deaths were prevented per 1,000 patients treated. And 15 heart failure deaths were also prevented within 1 month of therapy. Next, please. So, please go before. My question will be to, can you get to the thing? Okay. So, just hold on. So basically what you can see is, next slide, please. So you can see that across the board, when you give for long term and when you start within first week of therapy, across the board reduction in mortality, 20% reduction in SAVE trial, ARI 27%, HOPE trial also not exactly this group, but same ramipril drug, 26% reduction, and ISIS-4 about 7% reduction. So these across the board reduction, slightly different with different drugs. As you might notice, ramipril consistently giving around 25%, captopril up to 20%, and lisinopril, weakest among them, up to 10%. So next, please. So my question to Dr. Piyush Jain will be, sir, will you start an ACE inhibitor in all patients with ACS, whether revascularization procedure was performed or not performed, to get mortality benefits?
Thank you. Can you hear me?
Yeah, but we cannot see you.
Yeah.
Yeah.
Okay. Can you see me now? Okay, right.
Not yet.
So
yeah, we can see you now, sir. Yes.
Okay. So this is quite a loaded question because in medicine there is nothing like all or none. Because even if there is an overwhelming evidence in favor of a particular treatment, it cannot be applied to each and every patient. First of all, let me just say and try to summarize and maybe add on a few points regarding the benefits of ACE inhibitors in acute coronary syndrome. So, besides improving the left ventricular function, it also reduces the severity of mitral regurgitation, which is present in some cases of ischemic, event. And then, if given very early in the evolution of myocardial infarction, it also does lead to a reduction in the risk of cardiac rupture. So, as you said correctly, there is a reduction in the mortality by about 25 to 30%. Uh, uh, Recurrent myocardial infarction occurs in the longer term, and also reduction in the risk of heart failure, which was actually not so well studied in the earlier studies. So, as far as the recommendations go, well, recommendations are that you have to start an ACE inhibitor within 24 hours of the onset of acute coronary syndrome, unless it is contraindicated or it is unsafe. So obviously there will be some cases who will not be candidates for ACE inhibitors, like patients who have ACS and they have got symptomatic hypotension, or they have got shock, or they have gone into acute kidney injury following shock, even though shock has improved. And then of course there are classical indications of contraindications to RAS inhibitors like bilateral renal stenosis. So we actually have to look into which patients are going to be benefited most, and that will actually constitute class 1A indication. So the American as well as the European guidelines, they are unanimous that ACE inhibitors are to be given in all cases of ST elevation MI with anterior location, low EF, which means low EF less than 40%, early onset of hypertension, heart failure, sorry, or they have diabetes or hypertension. This is a class 1A recommendation, and I will go with that. So one part of my answer says that I will start ACE inhibitor in all the patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits and other benefits like recurrent MI risk reduction and reduction in the risk of heart failure. But then, if you say all patients, that is basically a class 2A recommendation uh, uh, in ST elevation MI. Now, what about patients who don't have ST elevation and they have got non-ST segment elevation? Their ACE inhibitors are class 1A recommendation in patients who also have heart failure with reduced ejection fraction, diabetes, or CKD. Once again, unless contraindicated. And of course, if ACE inhibitor cannot be given, ARB is the second choice. So to be very brief in my answer, I will say I will not start ACE inhibitor in all cases with ACS to get various benefits, but I will like to put them on ACE inhibitors in majority of the cases, and the exceptions will be those where it cannot be given. And earlier the better will be the best choice.
Thank you, sir. Can I have the next slide, please? So basically, we have two groups, as Dr. Piyush very rightly said, whether you revascularize or they don't undergo revascularization. Of course, if there is no revascularization, then some studies show that benefit will be larger, up to 30% benefit in mortality reduction. But even in revascularized patients, especially those who have got left ventricular dysfunction, evidence of heart failure or diabetes, the risk reduction will still be up to 20%. So whether revascularized or non-revascularized, I think across the board, we see mortality reduction. Only thing, of course, is that the patient should be suitable. Somebody who's already in shock or has got severe, low blood pressure, systolic blood pressure, then obviously you have to wait till the blood pressure picks up. So next, please. So basically, now let us look at, having looked at ACE inhibitors, and just to summarize what Dr. Piyush also rightly said, that broadly, those patients who have no contraindication to ACE inhibitors should be given to each and every patient of acute myocardial infarction or non-myocardial infarction as well. ACS, all group of patients should be given, started early and continued for long-term period, because as I already showed you some trials where even persistent treatment for 3 years, 4 years, 5 years was showing significant benefit. So it should be continued for a longer term period and basically showing mortality benefit, irrespective of the fact whether they have been revascularized or they have not been revascularized. So coming to the second drug, that is ARBs. Can I have the next slide, please? Next slide, please. Again, there are a couple of trials available with ARBs also. The randomized control trials, Optimal in 2002 and Valiant in 2003. Optimal using losartan, 50 mg once daily compared with captopril, 50 mg TID, and valsartan and Valiant using valsartan versus captopril. Patients enrolled about 15,000 patients in Valiant study. Next, please. So coming to the Optimal study, what it did show was that there was no significant difference in the total mortality, but numerically in favor of captopril. So you can say that captopril was having lower mortality and with in this particular group of patients compared to the losartan, although not statistically significant. And so clearly there is no need to shift from ACE inhibitor to ARB like losartan in these patients, and therefore it cannot be recommended unless ACE is contraindicated for some reason, maybe because of severe cough. If you cannot use ACE inhibitor, then losartan or the ARBs may be an option. Otherwise, it does not show any added benefit of sartan over ACE inhibitor. Next, please. Similar findings with this Valiant study as well. Again, as you might notice, that the captopril numerically little better in mortality reduction versus very well-known sartan, that is valsartan, later generation sartan also, and the mortality is basically similar, but there was no additional benefit of using a sartan here, so therefore it cannot be recommended unless ACE inhibitor cannot be tolerated for some reason. Next, please. So my question to Dr. Nagendra Chauhan, sir, will you switch the patient to an ACE inhibitor if the patient at the time of MI was already receiving ARB for hypertension? So as we know, I mean, just to clarify the question, for hypertension, many people use ARBs and different types of ARBs are used. Now, suppose this patient was hypertensive and was receiving ARB, now has developed acute coronary syndrome. So now, would you want to switch from ARB to ACE inhibitor, knowing that there seems to be more definite benefit with ACE inhibitor, at least more data, and even some numerical advantage, if not statistically significant advantage, but at least numerical advantage. So would you personally want to shift from ARB to ACE inhibitor in the developing scenario of acute STEMI or acute coronary syndrome?
I think, sir, it's a very interesting question and very pertinent to our general practice because many patients are already on these medicines. So if we go into data from initial studies like value trial, which initially showed the AMI paradox. So there was a major fear about ARBs that they can cause increase in heart attack. And I think that was not just the this was real data which showed significant increase in the mortality, the MI rates, although not increase in the mortality, but MI rates were increased in patients on ARBs. So that's why ARBs were always considered inferior to ACE inhibitors. And ACE were always considered superior. And that's why the trials were saying that we should use ACE inhibitors as the first choice and ARBs only if patient is not tolerating ACE inhibitors. And that recommendation is still not changed, although you've shown two trials like Optimal and Valiant. Both have shown that they are almost equally efficacious in terms of benefits, but I think we have to take all these with a pinch of salt. If you go to the very recent registry, which is published in 2023, the Kamir NIH registry, which specifically look into this question, although this is not the randomized data, but it's registry data, it clearly showed that first 1 year, if you use ACE inhibitors post-MI, the benefits of ACE inhibitor over ARB were significant, almost 25 to 30% benefit in terms of all-cause death, cardiac death, and MACE events also. So definitely after 1 year, the benefit was not robust. I think this is explainable also, which we all know by the mechanism that ARNI or the ACE inhibitors versus ARB ACE are working by inhibiting angiotensin II, which prevents endothelial function, which improves cardiovascular remodeling, which prevents progressive atherosclerosis, and ARBs are working mainly by preventing angiotensin II inhibitors. So actually they are upregulating the angiotensin II in body, and which is not very good. Again, ACE inhibitors are beneficial in terms of preventing background of bradykinin also. And that also is helpful in terms of additional cardioprotective effects. So theoretically and practically in trials, everywhere it is proven that ACE inhibitors are superior. So I would prefer to shift to patients if they are not in so in general, what we consider ACE inhibitors are not as powerful antihypertensive as ARB, And this is a general notion that ACE inhibitors have more side effects like cough and all those problems. That's why people prefer ARBs. So generally speaking, for patients, if it is shiftable, most of the patient I would prefer to shift to ACE inhibitors because that is, in terms of data, is more superior. There are few patients who may not be tolerating the ACE inhibitors or in whom blood pressure may not be controlled. Now there is enough data that we should not combine ACE and ARBs in a single patient. So if patient blood pressure is not controlled and I have to give something, definitely I can change to ARBs again, but I will definitely try to shift them to ACE inhibitors if it is possible and if they don't have major side effects. Although cough was considered a significant side effect, but we have seen not more than 5 to 7% of patients actually having really cough. So it's generally well tolerated, and it is shown that in all subgroup of patient, the benefits are same. So we should prefer to choose ACE inhibitors over ARB in patient with AMI, and even if he is on these drugs and his blood pressure is controlled, it means he's not on very high dosage, definitely we should think of shifting to ACE inhibitors because it has more data and more benefits. Although there is some data to prove, like you have shown already, that you can continue ARBs also, but I would prefer to shift. Thank you, sir.
Yeah, thank you very much.
Can I add something?
Yeah, please.
Okay, fine. So Dr. Nagendra has pointed out, okay, ACE inhibitors are not very powerful antihypertensive. But I'll tell you the actual story. Some of the developed country doesn't have ARB as an antihypertensive drug. They don't use it even. And this I'm talking of New Zealand. They say if you have to take care of blood pressure, give higher dose of ACE inhibitor. There's nothing wrong. Unless patient is not tolerating, then only you can write ARB. Otherwise, you are not supposed to write. Even under government formulation, they do not supply to the patient. They tell them to purchase. So this is a real example of one of my patients who came from New Zealand. He told me, you write me ACE inhibitor because I will have to purchase ARB because in that country it is accepted. ARBs are equally powerful antihypertensive, but the dose may be given to be higher. So now continuing hypertension, ARB for hypertension is justified. But unless patient is having side effect. Otherwise, you can continue with ACE inhibitor even in case of hypertension and MI both. So this is very well accepted in some of the countries as a national policy rather. Okay.
So I think very rightly said, Dr. Vidyajan, and I think it will make things very clear, not only in MI STEMI situation, even in heart failure. More data is with ACE inhibitor and all the benefits are there with ACE inhibitors, and people seem to extrapolate those benefits to ARBs as well. So only reason to use ARBs should be when ACE inhibitor cannot be tolerated for some reason, maybe cough or some other reason, angioedema or something, which is very, very rare, of course. But only when it is not tolerated should one go towards ARBs. Otherwise, ACE inhibitors are the ones which have most robust evidence, not only in this situation, but in many others as well. So can I have the next slide, please?
I think, sir, just one small thing in this also. Dr. Vidyajan has rightly said, actually, the cost of ACE inhibitor is almost 1/8 as the cost of ARBs. And the data is not supporting, but definitely, this is definitely financially driven to some extent that ARBs are preferred over ACE inhibitors, but actually the data is more in ACE and they are most economical and more useful. That's why many countries like New Zealand are promoting this because this is important for financial health of the country also.
Right.
Good point. Next, please.
Thank you, sir.
So basically, just to summarize what the both of them told us, that ACE inhibitors are generally first-line agents post-MI because they are known to reduce mortality. Switching to ACE inhibitor must be or can be definitely be considered the best evidence protocol for switching from ARBs for post-MI patients, especially if the patient can tolerate it. Only one group of patients where you know that patient was given ACE inhibitor for hypertension but could not tolerate, and therefore this patient, because it could not tolerate, was switched over to ARB. In this patient, if they develop MI, maybe you still keep continuing with ARBs. Otherwise, in all other patients, as per our panel, recommendation, they should all be switched over to ACE inhibitors. So,
right. Correct.
Yeah. Okay. Next, please. Now coming to the third, which is the new kid on the block, which is ARNI in this situation. So ARNI is available for heart failure patients, have ref patients for a long time. But here it is like relatively newer indication. So next, please. So the basis of this was this particular trial, which was showcased in ACC 2021, which is ARNI following post-myocardial infarction, Paradise MI trial. So this is the data, or this is the evidence for using ARNI in these patients post-MI. Let us look at this data. Next, please. Let us first look at the trial. So again, it started nearly first day, in many cases, 0.5 days to 7 days. Same group of patients, ejection fraction less than 40%, with or without, with or evidence of pulmonary congestion. So either they had ejection fraction less than 40% or had pulmonary congestion, or both. And normal distribution, as you might see, age more than 70 years, EGFR less than 60, diabetes, prior MI, ejection fraction less than 30%. And these are the things. Exclusion criteria were if somebody had prior evidence of heart failure, if somebody had clinical instability, if somebody had chronic renal disease with EGFR less than 30. And here what they did was, again, enrolled about 6,000 patients, a half on ARNI, 2,000 milligram dose, and half with Ramipril, 10 milligram dose. And basically followed up for a period of about 2 years, looking at cardiovascular death, heart failure hospitalization, and OPD development of heart failure. And secondary endpoints were these separately. Next, please. So interestingly, just a small point, while US was the largest enroller and Netherlands was number 2, India was the third highest enroller in this particular trial, contributing to 330 patients and highest in the Asia Pacific region. Next, please. So looking at the clinical profile, nicely matched. About ratio between STEMI versus non-STEMI was 3:1. And nearly 90% were thrombolized. Majority, more than 2/3, had anterior MI. Randomized on an average mean of 4 days. Ejection fraction mean about 36%. Philip class, more than 50% had Philip class 2 or more. So they were having pulmonary congestion, as you might notice. Basically, gold standard therapy was all given, dual antiplatelets in more than 90%, beta blockers in nearly 90%, and aldosterone antagonist unfortunately only in 40%, but statins 94%, and ACE inhibitor, prior ACE inhibitor people were on ACE or ARB. About 3/4 were already on ACE or ARBs. Next. So here is the outcome, and as you might notice, the primary outcome was cardiovascular death, first heart failure, hospitalization, or outpatient heart failure, which was not different between the two groups. Although numerically, ARNI showed some benefit, but statistically, it was no different, and both had similar primary outcome after the therapy. Next. And if you look at the educated primary outcome, no difference in primary outcome, no difference in cardiovascular death, no difference in heart failure hospitalization, only a trend towards reduction in outpatient heart failure. Not significant, but a trend towards reduction in outpatient heart failure in the secondary endpoint. Next. Although investigator-reported events were higher, but as you know, particularly the outpatient heart failure was reduced in ARNI patients. But as you know, the corrected or educated rates have to be considered for a trial of this type. Next. Now looking at secondary endpoints, again, as you might notice, there was no difference whether it was CV death and heart failure hospitalization, whether it was heart failure hospitalization and OPD heart failure, all-cause death, any other outcome you would see, except there was no much difference. Next. Looking at adverse event, which is very important, you will notice that hypotension was more in the ARNI group, and expectedly because two drugs are there. So it was a bit more in the ARNI group, and cough was also slightly, on the other hand, cough was slightly higher in the ramipril group. Here about 15% patients, classically we say that ramipril causes cough in about 15%. Here it was less than 15%, about 13% patients had cough, but 9% or about 10% in even an ARNI group had cough. So, but more important is the discontinuation because of cough or discontinuation because of hypertension. So next slide, please. In the slide, you see that practically very low discontinuation rates with cough less than 2.5%, about 2.3% compared to 1.2% with ARNI, and higher hypotension rate about 1.3% leading to discontinuation versus ramipril 0.6%. So this was the only difference among the discontinuations in the two therapy arms. Next. And if you look at all deaths, again, there was a slight numerical advantage with ARNI, but no statistical significant difference. So basically, generally no difference between the two groups as far as the death or mortality was considered. So basically no benefit of having ARNI versus ramipril in this group of patients. Next. So basically, what they summarized was that ARNI did not result in any significantly lower rate of cardiovascular death, heart failure hospitalization, first heart failure hospitalization, or outpatient heart failure requiring treatment. The other thing was the safety and tolerability of ARNI in this population was comparable to ACE inhibitors. Next. So then not surprisingly, a lot of comments from different people. Medscape reported Paradise MI, ARNI can't beat ramipril in acute MI. TCD-MD also came out that ARNI does not surpass ACE inhibitor after MI. Medscape also had another comment that it basically investigator questioning why should I use ARNI after MI when the same benefits can be accrued with ACE inhibitor like ramipril. Next. And more of the same, even ACC said that ARNI did not outperform ACE inhibitors after MI, and HCP Live also reported the same, that although there was a significant reduction in heart failure event, outpatient heart failure event, but whether that alone can be of much benefit because it's only a secondary endpoint. So next. So my question to Dr. Vidyut Jain is, sir, what do you think? Why do you think ARNI could not show any statistically significant reduction in primary endpoint? If you look at the HFrEF group, it did show at least a mortality advantage even versus the standard ACE inhibitor therapy available. But here in STEMI, what happens? Why did not ARNI show any significant reduction? At least in primary endpoint, that is what we would consider in Paradise MI trial.
Thank you very much, Dr. Mishra. We all got excited with the introduction of ARNI in somewhere in 2014-15 when Paradigm trial came in, and it proved that it's beneficial in the chronic heart failure over ACE inhibitor. So excited by all this, the thought came, what will happen to the patient if we use in the post-MI condition? Although we have been using ACE inhibitor for quite some time, say maybe around 2000 onwards, everyone had an experience around 10 to 15 years of using ACE inhibitor in post-MI condition. Now, excited by the result of Paradigm trial, many other trials came for the ARNI. So then this particular trial, which had around 6,000 patients, couple of important points for this trial. This trial had many patients who were above the age of 70. This trial had many patients who had atrial fibrillation also. And this trial had a patient ejection fraction was less than 36%. Now, when this patient were given this ARNI versus ACE inhibitor, the main problem came was the hyperkalemia and hypotension. So hypotension was more than as compared to ACE inhibitor. which led to the discontinuation of drug. Number two, hyperkalemia, more than 5.1 was seen in around 20%, and more than 5.5 was seen in another 14%. So that also prevented the use of the continued use of the RNA in the post-MI case. Now, how does it differentiate why patient primary event rate was not significant statistically? We should also come to know what does RNA does and what does the ACE inhibitor does. They are basically kinase inhibitor. Kinase inhibitor is a property of vasodilating. Kinase inhibitor is a property of plaque stabilization. So plaque stabilization was more with Remipel that we know, and we have been documented it and it has been accepted. So ultimately, to prevent the next event in the Paradise MI trial, you need to have around 83 patients with ACE RNA. Number needed to prevent the one event. If you need 83 patients, then possibly you will not feel very much satisfied. And you will possibly continue using the ACE inhibitor, which you haven't used. And we all agree that numerically, everywhere we are seeing that some better result with sacubitril or RNA. But at the same time, we are numerically seeing potassium is going high, hypotension is more, then the discontinuation rate was higher. That's why RNA ultimately was found to be not preferred over the Remipel, which we have been using. And very important thing, people always forget that we don't have much evidence on the plaque stabilization with RNA ACR. However, with Remipel, we have, yes. And we have been talking, it helps in the endothelial dysfunction also. So ultimately, in the long term also, patients should get benefit of the all these things, including kinase inhibitor property, which prevent fibrosis and prevent the sudden cardiac death also. That is what I think so.
Yeah, thank you very much, Dr. Vidyut Jain. And very nicely, he said that what we have done, at one hand, we have Ramipril. On the other hand, we have actually a ACE inhibitor. And on the other hand, we have Valsartan. So we have been discussing, whether there is any additional benefit of ARBs on the ACE inhibitors, and we find that there is not. Rather, numerically, it seems that ACE inhibitor seems better. So that is one point, that we replaced one drug that was very well known in reducing mortality with some other drug, which also is useful, but maybe not. We don't know whether it is equal to, at least guidelines say it is not equal to ACE inhibitor. So we have that kind of drug. And addition, what we have done is we have added nephrilysin inhibitor, or we have added sacubitril. And next, please. Next slide, please. So here, basically, as I said, there is the problem is that what sacubitril does is basically acts on natriuretic peptides, and it decreases the preload and afterload, which is more useful in heart failure patients and may not be of much use in MI patients. So the mechanism, that the added mechanism of RNA is not very much useful, perhaps in this situation, where we are basically focused on ischemic damage and ischemic event, and not so much on preload and afterload or natriuretic peptide properties. So that may be one reason for that. And the other thing is that, of course, ACE inhibitors are so effective in acute coronary syndrome patients that having additional benefit, as Dr. Vidyut Jain himself said, additional benefit by another drug would require a large number of patients to be used to get a small benefit. So that is I think, the main reason. Next, please. So now, we have discussed what is the data, but I think what is important is that what are the guidelines, because ultimately we are supposed to follow the guidelines. So let us look at the guidelines. I think Dr. Piyush Jain already, next please, already discussed them for us a little bit. We see that ACE inhibitors for a STEMI, especially if in anterior location with ejection fraction less than 40, with early heart failure evidence, with diabetes or hypertension, have 1A indication. So very, very strong indication in this group of patients. STEMI with anteriorly located ejection fraction less than 40% with early heart failure, diabetes or hypertension. Whereas for ARB, this evidence is 1B. So slightly less evidence for ARBs in the same situations, early heart failure, diabetes, or hypertension. But even for patients who do not have these high risk factors, so any regular STEMI patient within 24 hours, it is an indication of 2A. So again, very robust evidence in favor of using ACE inhibitors in all STEMI patients within 1 day of therapy, within 1 day of presentation, if no contraindications exist. Next, please. Similar things come out with ESC guidelines also, and it says same things, ACE inhibitors or ARBs in case of ACE intolerant, indication 1A for high risk groups, ejection fraction less than 40%, heart failure, diabetes, CKD. So these subsets, evidence 1A. Beta blockers also, if you would notice, has an evidence of 1A, and MRAs have also evidence of 1A in these group of patients. So basically, if you have this group of patients, you have to start all the 3 therapies simultaneously at the same time. Next, please. And basically, when to enter, I think that is another thing. So as soon as the patient presents, first thing is to thrombolize or reperfuse. That is the first thing, whether it is STEMI or whether it is cardiogenic shock. Then within first 24 hours, you would like to start ACE inhibitors. Watching for 24 hours, immediately after that, you can start beta blockers if no contraindications exist, and you can keep looking for contraindications. If contraindications go away, you can start beta blockers after the very early stage of MI. Aldosterone can also be introduced within around 1 day of therapy, and then keep evaluating. If beta blocker is not giving initially, keep evaluating whether ultimately beta blocker can be given, because as you notice, very strong reduction in morbidity with beta blockers as well. And finally, at the discharge, start up titrating these doses and try to get to maximal dose as soon as possible. Next, please. So same thing, even Jack, based on the ARI study, has underlined the usefulness of ACE inhibitors in post-MI heart failure patients. Beta blockers, as I said, high dose may be harmful early on. So after 24 hours, we evaluate the need for high dose beta blocker and then start giving it unless there is a contraindication. But ACE inhibitor, you can start within 24 hours. So I think that is important to understand in any of these group of patients. Next. So my question to Dr. Piyush Jain is, sir, will there be any change in the guidelines now that we have these Paradise MI results present with us in post-MI patients?
Thank you. I think this question has been framed very carefully. So we all know that the present American and European guidelines, they don't recommend ARNI in acute coronary syndrome. And that is based on Paradise MI study. The results of Paradise MI study, they are consistent with the benefits extended by the early initiation ACE inhibitor in acute MI, which are not exceeded by ARNI. I will not say that ARNI was not useful. I will say that it was almost as effective or equally effective to ACE inhibitors. But given various factors, including the cost and lack of clarity regarding the long-term benefit of ARNI in a patient with acute coronary syndrome when initiated early, we know that ACE inhibitors are effective when started early and continued for several years thereafter. So there is little chance as of now for a change in the role of ACE inhibitors in acute MI, and they will continue to be recommended in near future also. But there are a few questions, regarding these patients who had acute coronary syndrome and they were given ACE inhibitors because there was no contraindication. We expect them to have benefits. But then what about the patients in the setting of acute coronary syndrome who are intolerant to ACE? So I'm not still very clear whether a patient who has got history of cough due to ACE inhibitor or angioedema, whether a ARNI should be given right on the day one or not. That is one question. And the second question is, and I have discussed this with many colleagues with knowledge about cardiology. Uh, we know that a patient with chronic heart failure will be benefited more by ARNI rather than ACE inhibitors. So any patient with the acute coronary syndrome will actually enter a chronic phase, and what exactly is that is subject to the opinion of the treating doctor. But should we switch over from ACE inhibitor to the ARNI at some stage during the life history of the patient to give a benefit, because any patient who had myocardial infarction sometimes in past, and now the patient is symptomatic due to heart failure, and we always try to make it shift from ACE inhibitor to ARB, or no, not for ARB, in fact, the ARNI. So, for a patient with history of ACS, what is that right time? Is it few weeks, few months, or few years? I really don't know. So, I would just like to take the opinion of our other panelists also in this regard.
I think very right, sir. What sir said was two things. That in a regular patient, who develops a STEMI, because a lot of data, much larger amount of data is available with ACE inhibitors, and whatever data is available with ARNI did not show any significant benefit versus ACE inhibitors. So we would like to continue giving ACE inhibitors, but during the course of therapy, suppose patient develops a symptomatic heart failure, then in that case, there may be a case for switching over from ACE inhibitor to ARNI if the patient has symptomatic heart failure during the course of therapy. So starting probably with ACE inhibitor, but then watch if patient has symptoms of heart failure with ejection fraction less than 40%, then you might consider giving ARNI. What other people think, sir? Dr. Vidyut Jain, sir, you have any comment on this?
Well, of course, new guideline, we agree, definitely are important. And we have been using all this ACE inhibitor for a long time in post-MI patient. And we will, I think, stick to our older guideline, which have been always recommending the ACE inhibitor in post-MI patient. And for Paradise MI, they recommend in case we have to find out the real benefit, we have to do longer study, larger number of patients. And then if we can document a less number of patients are required to prevent one event, then possibly it will be accepted at later date.
Yes, sir. Thank you, sir. Dr. Nagendra, you have something to add, or you are okay?
Yeah, I think, sir, the important thing we have to understand in patients with MI is that it's a very broad group of patients. There are some patients who are coming very early, some patients who are coming very late, some patients get intervention or primary angioplasty, some patients get thrombolysis, some patients get nothing. So this is a vast group of patients with different subgroups. If we do a subgroup study, possibly we could find a long outcomes, but as a generalization in these patients is not a good idea. And I think for that, we all know that ACE inhibitors have a proven data for all kind of patients with ACS, so that is more relevant here. And for a specific subgroup of patients who we know that will develop they present very late and they will develop a heart failure. So those are the patients in which chances of recovery are less. If we do a study on them, then maybe we could find something. Otherwise, even SGLT2 inhibitors were not beneficial in the studies. So no specific drugs were beneficial in these subgroup patients, because I think this is not a subgroup which is to be studied. We should divide this into multiple groups and then we should study.
Okay, thank you. Next slide, please. So basically, I think this is the summary of what the panel already said. While ARNI was numerically a little better, but not statistically superior. So this subtle improvement may not warrant any change in guideline at the moment. And of course, as foretold by all the panelists and all the experts, that this is a good area for future trials, and subgroups can be identified where it can be done. But as far as now, those patients who tolerate ACE inhibitors, and those patients should receive ACE inhibitors. Only those patients who cannot tolerate ACE inhibitors or who already have a pre-existing heart failure. Only in those cases, ARNI may be recommended. Otherwise, every patient ACE inhibitor should be used. In the course of time, if the patient becomes symptomatic despite optimal medical therapy, then switch to ARNI might be considered. And as Dr. Nagendra Chauhan already said, the future trial might be conducted in different subset of patients, different high-risk post-MI patients, and different groups to see where these other drugs may be beneficial. So I think this is the main focus. Next, please. Another question to Dr. Nagendra Chauhan. In the post-MI, post-revascularization patient, when would you start ACE inhibitor therapy, at what blood pressure level? And what will be your starting dose? And how will you go about it? So some practical questions. You have a patient who has MI and has undergone revascularization. Now, what are the things that you will look for? In other words, what will be contraindications for ACE inhibitor therapy? And suppose you start ACE inhibitor, what dose you start, how you go about it?
So I think it is very rightly pointed by you, sir, that we should start considering ACE inhibitors as early as in first 24 hours, which is very important. Because data show that if you start this drug within first 24 hours, the benefit is, if you go into numbers, 50 lives saved per 1,000 patients treated. If you compare this with thrombolysis, which is considered the ultimate goal, the actual number of patients saved lives is just 30. So as compared to ACE inhibitor, lives saved was 50 as compared to thrombolysis, which is just 30. So this is even more important to consider this drug. But definitely once you are starting this drug, you should consider certain things in patient. Most important thing is patient should not be allergic to this, definitely. And patient should not be hypovolemic. Many patients who are having right heart, the inferior MI or RBMI, they're hypovolemic. So we have to be very cautious in starting this drug. In these patients, they should not be hypovolemic. These are the two important things first to consider. The second important thing we should consider about their renal functions. So although nowadays we know that ACE inhibitors are beneficial in patients with decreasing renal function also, but the problem with this is this can cause reduction in renal function further. So any patient who is having rising trend in kidney function, we should be avoiding this. If there is a significant renal dysfunction, we should be avoiding this. If patient is having a first dose hypotension, we should be avoiding this. In patient with already having liver dysfunction or patient with severe heart failure and liver failure also along with this because of shock, this should not be a good drug to start. Anyway, so these are the important things we should remember before starting. But otherwise, we should think of starting as early as possible and as tolerable possible doses. As we already discussed that what dose we should start. I think my practice is very simple, that any patient who's having blood pressure between 90 to 110 or 120, I start with the lower dose, 1.25 milligram of ramipril. Patients who are having blood pressure more than 120, 110 to 130, I start with 2.5. And patients who are having hypertensive, I start with 5 milligram. So this is what my strategy is, but definitely most important is to follow them. This is very important that they should not develop renal dysfunction. So a 10% rise in their renal dysfunction is acceptable over a period of 1 to 3 days. But if it is going more than this, then definitely we should stop this medicine. Patient should not develop first dose hypotension. We should look into it. And very rarely patient can develop neutropenia, anemia, or thrombocytopenia or reticulocytosis, which is a very rare side effect. So which also we should monitor in due course of follow-up. And the other important thing is about potassium. So if patient is developing hyperkalemia, then up to 5.4 we generally accept. If it is going more than 5.4, then we have to reduce the dose. These are the important things. But before this, we should check that if patient is consuming any kind of medicines or food articles which are having high potassium. So these are the important things, definitely. And how to titrate. What I routinely do is patient generally are asked to come on first follow between 4th to 7th day. If they are tolerating well, I increase the dose to double whatever the dose I started first. The maximum tolerable dose generally for patients like this who are not hypertensive is generally we can go up to 10 milligrams. And if patient is hypertensive, we can go even up to 20 milligram for ramipril. And there is similar kind of doses available for other drugs, but I think I prefer ramipril over others because of multiple reasons. I think we'll discuss this also. afterwards. Thank you, sir.
Dr. Vidit, you have any
Yeah.
comment on this?
I think he rightly pointed out the systolic blood pressure should be at least 110 before starting the dose, which is correct. And number two, depending on the tolerability, he will increase the dose also to get the maximum benefit. It may be 2.5 if he's tolerating, and systolic blood pressure is maintained to 110, which is minimally required for good cardiac tissue perfusion, as well as diastolic pressure should also not go below 80 or 70 at least. So this is the one of the most important criteria as far as the any cardio post myocardial vascularization also. Rest of things are, of course, we can up titrate always, monitoring potassium, monitoring sodium, monitoring creatinine, and monitoring systolic blood pressure.
Next slide, please. Basically, interestingly, while we are talking of more than 110, many studies have shown that you can start ACE inhibitors if systolic blood pressure is anything more than 100 or more. Even if it is less than 100, between 90 to 100 also, you can start, but with a lower dose. So this is what Western people guidelines suggest. But for systolic blood pressure less than 90, definitely, this may lead to hypertension and further organ perfusion deficit. So it should be avoided clearly. So I will leave to the experts to decide. This is what the Western people say, that anything more than 100, you can safely start. And between 90 to 100, you start with a low dose. But of course, patient should be hemodynamically stable. And as very rightly Dr. Nagendra said, that you have to keep looking at the renal function and serum potassium levels. Anything more than 5.4, you have to stop. If renal functions are deteriorating over next few days, beyond few days, then you have to be very careful and maybe you have to change it or stop it. Next. Regarding the lowest dose to start, generally the recommended dose is 2.5, and which can be up titrated every 1 to 2 weeks as the patient tolerates, and then trying to achieve the target dose of 10 milligram per day as soon as possible. Next. Next, please. So now my question to Dr. Vidyut will be, do you think that all ACE inhibitors are equally beneficial in acute MI? Is it a class effect or is it a drug-specific effect? So
Okay,
that
fine.
is the question.
Yeah. So first we should realize what ACE inhibitor we have in our basket. We started with the captopril, then we got enalapril. With these two ACE inhibitors are short-acting. Had to be given at least twice, or captopril has to be given even 3 times a day. Then we got the drugs like perindopril, vinapril, and the trendopil. They are little longer acting. Then we got the another drug which is known as remipil. So any drug which is short acting will have less benefit. So we have to use a drug which is long acting. Then one important terminology is there, tissue penetration. What is the tissue penetration of the particular ACE inhibitor? The tissue penetration has been found to be the better with the remipil and the perindopril. Then one more terminology came, tissue ACE inhibition. What is the tissue ACE inhibition property of that particular ACE inhibitor? So again, it is better with the remipil or perindopril. Then one more thing came. What is the effect of ACE inhibitor on endothelial function? As well as what is the fibrinolytic properties of this ACE inhibitor, particularly in the vascular tissue itself. So all studies have been done at animal levels also, and it has been found remipil does little better all this job. Better tissue penetration, longer acting, as well as the more fibrinolytic capacity and endothelial function improvement. So all this put together, possibly in the current available scenario, we have got drug like ACE inhibitor, particular ACE inhibitor is remipil, then perindopril. And the other would be, since they are short acting, so possibly benefit will not be good enough and patient may miss the dose also. So we always look for the better drug, which is long acting and with proven benefit in the all endothelial dysfunction, plaque stabilization. So I think we have on board available is either remipil or perindopril, something like that.
Thank you so much, sir. Very right. Next, please. What we would want to show you is next slide, please. A comparison between the different ACE inhibitors. If you can get the next slide.
Dr. Ronak, please change the slides.
So basically, as Dr. Vidyut rightly said, we really, want to see whether it is a class effect, which of course it is. There is some class effect. All the ACE inhibitors are beneficial if you compare with at least ARBs and placebo. So all are effective. So there is some class effect, but whether there is any specific effect. And as Dr. Vidyut rightly said, the specific effect could be the duration of action, one, the tissue penetration, two, the tissue effectivity. So we know that renin-angiotensin system acts on this renin-angiotensin system. So kidneys and other areas. But not only that, they even act on all other tissues. For example, they act on kidneys, they act on heart, they act on other tissues as well. So what is their action of ACE inhibition in the tissue level? So that is what we are talking about, especially the vascular tissue, so heart and blood vessels. So what is their effect? And that is important. And that may be different between different ACE inhibitors. And then, of course, the function, their action on endothelial function and their action on lysis. These are the things which are useful in among the ACE inhibitors. Next, please. So if you look, there is this some data available of the comparison between various ACE inhibitors. More than 7,500 patients of MI studied after discharge. 1/3 of these ACE inhibitors studied were enalapril, another 30% lisinopril, about 12% ramipril, and then rest of the drugs, perindopril only 3%. But these were the ACE inhibitors studied among each other for the reduction of mortality, which is the hardest endpoint. So what they did was they studied all these ACE inhibitors and looked at their impact on mortality and compared with each other. Next, please. So what it showed was that captopril was the least effective of all these for several reasons. One, as short-acting, short half-life. Other, no tissue penetration or no tissue ACE inhibition. And ramipril was the most effective, as you can see in this particular chart, because of various reasons: longer acting, better tissue penetration, better tissue ACE inhibition, action on endothelial system. So various reasons why ramipril may have a significant advantage in lowering mortality after MI within first year versus other ACE inhibitors. Next, please. So my question to Dr. Piyush Jain, sir, post-revascularization, if you find a left ventricular systolic dysfunction of less than 40%, but without clinical heart failure. So we have a patient who has MI with LV dysfunction, but no evidence of symptomatic heart failure. Will you put this patient on ACE inhibitor or ARNI? Coming back to our previous question, again, here we don't have a symptomatic heart failure, but we have other things: MI, revascularization done, and even ejection fraction less than 40%. What would you do?
I am not the previous issue. So let's say a patient who has revascularization for ACS. So there is very little reason to choose ARNI over ACE inhibitor as found in Paradise-MI trial. Though it was not examined specifically in revascularized patients, but in Paradise-MI trial, 90%, almost 89 or 90% were revascularized. In for stable coronary artery disease, once again, there is very little rationale for choosing ARNI over ACE if there is no clinical heart failure, because the patient is in NYHA class 1. As you will see, all the clinical trials of ARNI, clinical of MRAs, they actually included only those patients who had been symptomatic, at least NYHA class 2. They had excluded patients with no symptoms. So it is difficult to say at this moment, in the absence of a specific clinical trial in asymptomatic LV dysfunction, whether in the setting of chronic CAD or in the setting of post revascularization for ACS, whether any will perform better than ACE inhibitors. And therefore, asymptomatic LV dysfunction, if you talk about class 1A indication and unequivocal choice of drugs, only two drugs stand out. One is beta blocker, which is most effective, and then ACE inhibitor, which is very effective, but not as effective as beta blockers. So beta blockers and ACE inhibitors, these are the two ones which are to be used. Many clinicians use MRA, they use ERNI instead of ACE inhibitor interchangeably. But the evidence for the benefit of ERNI in asymptomatic person with LV dysfunction is very little. So that is what I would like to say.
Dr. Vidyut Jain, sir, would you agree or you have some other opinion?
I think almost same. Yeah.
Okay. Dr. Nagendra, would you like
I
to
think,
add
sir,
something?
Dr. Jain has already described quite well. So I think this is what I also do in my practice.
Great. So I think we have consensus here, and all agree that here ACE inhibitor. Next slide, please. ACE inhibitor is the way to go, and as we already discussed, they remain the first line therapy based on many trials, including SAVE, AIRI, TRACE. Paradise AMI is only one trial, which also did not show any statistically significant reduction in these group of patients. And therefore, while it is equal to ACE inhibitor, but it does not have any added advantage. And because of several other facets of heart failure treatment, I think ACE inhibitor very clearly remains the first drug to be preferred and the first or the gold standard for therapy in these group of patients. Next. So what I would say is, and I will come back to the experts, start with ACE inhibitor in all these patients in absence of symptomatic heart failure. Begin with low dose 2.5 milligram, titrate every 1 to 2 weeks to reach a maximum tolerated dose or 10 milligram of dose, unless there is hypertension to increase it. Then, if the patient during the course of time develops clinical heart failure symptoms, and please notice, if the patient develops clinical heart failure during the course of the therapy, then it might be considered to switch to ARNI. Therefore, in asymptomatic post-MI patients without heart failure, direct initiation of ARNI isn't supported by any evidence. And unless there is a contraindication to ACE inhibitor therapy, like cough or angioedema, even in that case, you would not use ARNI, but you would use ARB, because there is data with ARB for those intolerant to ACE inhibitor therapy. ARNI you would only use once after starting the treatment. Over a course of time, patient develops clinical heart failure. Only then ARNI to be used. Next. Before that, anybody in the experts has any opinion on that? Anybody wants to add something, start anything? Okay. I think, yeah, somebody wants to say something? Dr. Piyush? Okay, no.
So, I would just like
yeah.
to sum this up, and I would like you to rather sum it up to say in what situations ACE inhibitors are preferred over ARNI, and in what situations ARNI should be preferred over ACE inhibitors. So, any thoughts about it?
Yeah, I would say only those patients who have symptomatic heart failure. There may be, and with a reduced ejection fraction, of course, symptomatic heart failure with reduced ejection fraction. In those cases, I may like to prefer ARNI. But if the asymptomatic patient, I would, if ACE are not tolerated, I would go for ARNI. Okay.
For patients with diabetes or kidney disease, and there is a case for ACE inhibitor versus ARNI. Uh, Given the evidence of the rhinoprotective effects of ACE inhibitor, do you think that a patient with CKD who is a candidate for RAS inhibitor therapy, ACE inhibitor will be more useful, or ARNI will be more useful? Because there is some data showing that ARNI is also effective and efficacious in reducing the progression of renal disease. Does the data regarding ARNI in this respect as robust as ACE inhibitors, or you would still like to say that there should be more trials with ARNI?
I would say, sir, for the sake of thing, first line of therapy, I would say would be ACE. And then I will, over a period of time, watch and see if the patient is developing heart failure, if the patient has worsening renal dysfunction. If those kind of things are there, then maybe I would start thinking of other drugs than ACE inhibitors. Otherwise, I would, as a rule, stick to ACE inhibitor as a first line therapy, unless the patient is intolerant to ACE.
Yeah.
In my practice, I would do like this. I mean, everybody can have some other ideas. Yes. Anybody else?
The other point is regarding the cost, actually. In a cost resource limited country like India, given the differences and the benefit with the ARNI versus ACE inhibitors, do you think for the masses and as a public health policy, ACE inhibitor should be preferred over over the ARNI in a large group of populations? Or, I mean, cost effectiveness in our country actually has not been worked out.
I agree.
My gut feeling that ACE
inhibitor
might be a good choice.
Yeah.
Unless there is a strong case for ARNI.
Yeah,
like in
so
chronic
there
heart
could be
failure,
small
symptomatic.
groups. There could be small groups, as you said, CKD, pre-existing CKD, and those with intolerant to ACE inhibitors, and those with severe symptomatic heart failure. I mean, those are the groups where we would like to make a deviation. But for the sake of clarity and for the sake of at a national level, I would say that a broad group of patients, more or less, ACE inhibitor should be the first drug to be tried.
Yeah, very correct.
Next, please. So, Dr. Nagendra, what are the beneficial effects of ACE inhibitors? I mean, basically, same question.
It was the same question which was repeated. Dr. Vidyajan has already answered this very rightly.
Why you would think they would behave differently? I think Dr. Vidyut already told us why they behave differently, different ACE inhibitors. If you want to add on to it, then
I think Dr. Vidyut has already explained very well why they behave differently. Only thing is that you have also shown data, and we have enough data to prove that ramipril and pranipral, if they be considered as a second drug, are superior in terms of data. We all have seen this. There is enough evidence to prove this. So these are the two preferred drugs. I always prefer ramipril over all other drugs in most of my cases. And the data has already shown, and the mechanism already was explained. So both ways we have the win-win situation. So we should prefer this drug over others. Although it's a class effect, we all know. But definitely every drug has the potential which is different from others.
Great.
I think nothing else.
Great answer. Next, please. Dr. Ronak, can we shift the screen?
Dr. Ronak, please change the screens.
I think the next.
Okay, so I think the same thing we already discussed. A couple of things that are very important are, among the 4 things that we discussed, most important are, of course, half-life differences. Those with longer half-lives are more useful, as Dr. Vidyut already told us. And those with the better tissue penetration, like ramipril, are always much better because they are, in context of heart, useful in cardiac remodeling and basically even, affecting the myocardium. Next, please. Dr. Ronak, next, please. So what about cough? As we noticed that while cough occurs in about 1 in 6 cases of patients who are put on ramipril therapy versus 1 in 10 with ARNI, but really, as a cause, serious cause for discontinuation, it occurs in very, very few patients. So only about 2.3% versus 1.2%. So I think hardly any difference. So I don't think cough makes a lot of difference in this whole paradigm. Next, please. So finally, I think thank you very much, ladies and gentlemen, for being here and participating in this discussion. And I don't see there is any question or comment from any of the participants. So I would finally end up with the take-home messages. In the post-MI patients with left ventricular dysfunction, ACE inhibitors based on several trials, SAVE, TRACE, ISIS-4, GC3, CCS1, and many other trials have consistently shown reduction in not only cardiovascular mortality, but all-cause mortality. And while there is some class effect, it seems that some ACE inhibitors, particularly ramipril, seems to be the preferred ACE inhibitor, especially in elderly. Then Paradise MI was the only trial comparing ARNI with ramipril in acute MI population, but it did not show any significant benefit over ramipril, and the maximum benefits are confirmed by are conferred by ramipril 10 milligram dose started in 1 day of the MI event, and up titrated as within a 1 to 2 week period to the maximum tolerated dose as soon as possible to achieve the maximum effects. Thank you so much.
Thank you.
Any other comment by any of the experts, Dr. Piyush?
I don't think we have actually covered a lot of ground today. Thank you very much for being, so fluent.
Okay. I think we have overshot the time as well, I think.
Right.
Yep.
So thank you so much, our esteemed faculty, for the wonderful discussion. I'm sure everybody who has joined in today has learned something new, and they have, you've added to their clinical practice as well, based on your current judgment. So thank you so much, our
How
faculty.
many could attend? Do you have any estimation at the moment?
It's 350 audience which joined across the country. So
Right, sir.
state-wise allocation will come, sir. So it was 350. Thank you very much for all your, sir, esteemed bringing out points. And I take this privilege to thank all the eminent faculties, those who have taken their time and joined this session, and even the delegates, those who joined and were get the benefit of this scientific session. Thank you very much, all of you.
Thank you.
So much.
Thank you. Thank you.
Have a good evening.
Have a great evening.
Thank you, Surendra ji. We will end that event.
थैंक यू अभिषेक जी, है ना? मैं कॉल करता हूँ आपको.
Done.